Thank you for joining the Brain and Mind Experts, the podcast where we talk about the world's most advanced biomarkers and innovative treatments for cognitive disorders, including neurodevelopmental conditions, traumatic, and neurodegenerative disorders at all ages. Each episode, we will bring the latest news and information about how we can potentially help the more than 55 million people worldwide. I'm Tom Dent, Executive Chairman of Recognition Health. In 2011, Dr. MacSweeney and I saw this growing health crisis, and we wanted to be part of the solution. We believed we could assemble professionals, processes, and strategies to provide a specific diagnosis and then provide the newest treatment and care for people with cognitive impairment in both the United States and the United Kingdom. We recognized the phenomenal progress in research and development over the last decade, providing real hope to those suffering from these conditions. There's so much we can talk about, so let's see how far we can get in the next 15 minutes. Let's start today with a discussion on memory loss and specifically Alzheimer's. Emer, it's always great for us to be together. We have so much fun, and we're going to talk today about Alzheimer's and memory loss, as you know. But I want to start with one of the most amazing things to me is how many people still say to me, oh, memory loss is just a natural part of aging. Is that really true?
No, it's not true. And in fact, it's probably this misunderstanding that is the greatest challenge to people getting an early diagnosis for the cause of their memory loss and other cognitive symptoms that are essentially just our thinking ability. And if people don't recognize there's a problem, then they don't seek an early diagnosis. And by inference, they don't get access to early treatment. And today, this is even more important because with the new medications that have come on the market in the last year or two, those treatments are designed for people who've got very early symptoms. And if they don't make a diagnosis early, then it may be too late.
It just always amazes me how many people still believe that it's not a disease. It's just a function of getting older. We've got to figure out how to dispel that.
Yeah.
So I think the other thing that people often ask me, and I'm not the right person to answer this because my background is not clinical, they want to know what causes Alzheimer's specifically. What's causing this memory loss? Is there something that they're not doing, something they should be doing? Do they need to eat more blueberries? Do they need to stand on their head? What do they need to do? What is the cause, the underlying cause?
So there's two answers really to this question. The first thing is that the cause, like many other diseases, in Alzheimer's disease, essentially it's neuroinflammation, which leads to an abnormal buildup of two key proteins in the brain. One is called amyloid protein and the other is called tau protein. And essentially these proteins destroy our brain cells and they have a predilection for the cognitive brain cells, which is why it starts with problems with cognition. But yes, there are all sorts of things that we can do to try to decrease our risk as a population. So there are disease modifying factors which we can do, such as exercise is probably the most influential thing on trying to reduce the risk of getting Alzheimer's disease, but also diet, a Mediterranean diet. The brain really doesn't like sugar. Sleep is important. Keeping the brain active is very important. And these factors, if we all do these as a population, will reduce the amount of Alzheimer's disease in the population. But also as individuals, it is very important that we focus on those key factors which will reduce the risk of Alzheimer's disease.
So I suspect every adult can't find their keys. They forget where they parked their car in the parking lot. They don't know where they left their sweater. So what should people worry about? What are some common concerns that would say, oh, I really do have a memory problem, versus just being distracted and multitasking and forgetting about things like normal people? What would be the early signs that a loved one or even yourself would say, we might have a problem here?
Mm-hmm. So first, just to reassure millions of people that, yes, we all forget names of film stars or names of movies, or every now and again we lose our keys or something. And that's quite normal. And to be honest, a lot of that is because we've all got busy lives and we're distracted, or as you say, we're not concentrating. But most people actually do know when they're experiencing problems with their short-term memory, which is usually the first presenting symptom, which is just different from what they've been aware of in the past. So it is forgetting details of recent conversations and events. It's forgetting details of phone calls. It's having difficulty maybe when you're reading a novel, when you put it down for a day or two, you have to go back and reread the chapter because you can't remember the storyline. But then it's also many other things. It's difficulties with all our different cognitive domains. So it's things like calculation difficulty. Your facility with numbers is just a little bit more difficult. Maybe using more generic words instead of specific words. So maybe for the mouse for your computer, instead of saying mouse, you'll say, oh, the thingy that I need to use. So it's just having difficulty with specific words and essentially your vocabulary shrinking, which often loved ones and friends will notice as well. It's also difficulty with what we call visuospatial. So that can be finding your way in a familiar environment. It can be difficulty and subtle changes in our planning ability. So essentially our sort of like higher executive function ability. So maybe planning a detailed holiday that has a number of different facets and components to it. And then the other thing, which is subtle, and all these things are subtle because they develop slowly, is behavioral changes. Very often people will say in retrospect that they noticed that they were becoming unduly anxious for no apparent reason. So anxiety, sort of just differences in behavior, maybe becoming slightly more socially withdrawn. These are all things to pay attention to. It doesn't mean any one of those makes a diagnosis. And actually, today, the diagnosis of this condition, like most conditions like diabetes, etc., or high cholesterol, is made by using biomarkers. So they're just pointers that people should think, I just know that something's not right. My thinking ability is just not as sharp as it used to be.
I think everybody today feels a higher level of anxiety just living life with all that's coming at us. And you said a word there, executive function. I hear clinicians use that people are losing their executive function. Can you just say a word? What does that really mean? Executive. What is an executive function?
Yeah. So I would just describe our executive function as our thinking ability. So what comes into that? It's planning, it's strategic thinking, it's problem solving, it's dealing with maybe dealing with dilemmas, it's making decisions and using the facilities in your brain to organize and operate sort of like on a daily basis. It is a difficult thing to describe, but I think everybody knows when their thinking ability is really sort of like changing. And actually, so many people will be aware of that early on in this condition. But what does tend to happen later is people lose insight. And then it's actually more difficult to identify there's a problem. And that is also when family and friends start to become more concerned. But I think it is very important that, like many conditions, you cannot make a diagnosis just on the basis of the onset of some of these different sort of symptoms. And in many instances, these can be totally reversible. They can be due to abnormal thyroid function, low B12, low folate, low mood, all sorts of things. It's really the problem is that one needs to recognize if something is wrong and take that seriously and seek a diagnosis and an accurate diagnosis. And the reason for that today, why that is so important, is because these new treatments that have become available are only effective when taken when symptoms are mild. Like many conditions, once the symptoms have progressed to the point where, yes, they're very obvious to everybody, that is too late for these new types of treatments. And that's the reason why we have to be more aware.
So I want to come back in a moment and talk about those treatments and those drugs that you mentioned, because I think we're going to find that very fascinating about what's happened in really recent years. But before we do, all of us are a degree away from knowing a family member, a friend, a neighbor, a colleague, somebody. And I often hear people say, well, they have dementia. or sometimes they'll say they have Alzheimer's and dementia. People are quite confused
Yeah.
about what is dementia. Now, I've
Yeah.
learned over the years that it's a huge umbrella term, but specifically, uh, what do people need to know about how many forms of cognitive impairment are there really, and should they be using the term dementia?
So dementia is just, as you say, it's just an umbrella term. So it's a bit like saying, I've got a headache. So if you say you've got a headache, there could be lots of different things causing the headache. You could have banged your head, you could have a migraine, you could have a hangover, you could have all sorts of reasons giving you a headache. So with dementia, dementia is just a constellation of symptoms. It essentially just means that you have cognitive impairment in two or more domains. So those domains are things like we talked about earlier. It could be concentration, it could be calculation ability, it could be language, it could be short-term memory loss. So in two or more cognitive domains that are progressive. So those symptoms have been progressive for at least a year. Now, what differs from what is a common term, mild cognitive impairment, as opposed to dementia,
And that's MCI.
that's MCI, is that when you reach the point where your symptoms qualify for the term dementia, it just means that you have lost the ability to conduct some of your activities of daily living, which are referred to as ADLs, or activities of daily living, independently. So an example of dementia is when you're actually unable to go shopping on your own, whereas mild cognitive impairment, you're aware there's a problem, is you're able to make your shopping list, you're able to either drive or you're able to order an Uber to take you to the shops, you're able to manage your shopping and come home, albeit you might need aids, reminders on your phone or a shopping list or whatever. But once you have lost the ability to do even some of these activities completely independently, that is when you've reached the point where your symptoms of cognitive impairment qualify for having dementia. Now, there's lots of different causes of dementia. It just so happens that as we all get older, the most common cause by far, over sort of like 65%, is due to Alzheimer's disease. But the other causes are vascular disease, Huntington's disease, frontotemporal dementia, Lewy body disease. There are lots of different causes of dementia.
And is it important that a person understands what their cause is as opposed to just broad day, I have memory problems and dementia?
It's essential because depending upon the cause of your cognitive impairment, or if it's reached the point of dementia, the treatment will be different. And the reason why, this is important is because either if you don't have a diagnosis, you don't get any treatment, or you may not be getting the treatment which is going to be the one that's most beneficial for you. And actually also understanding how that disease would typically progress is very important for family and friends as well, because anybody who's lived with someone with Alzheimer's disease will know that this is not a disease that just impacts the individual person. It impacts the entire sort of family because it's a very difficult condition to live with, as well as live with somebody who has this condition. And planning and understanding is crucial.
Well, let's move to talking about drugs and medication, which is hope. And as I understand and have been an observer now of this entire universe of memory loss, we've really not had any drug breakthroughs in decades upon decades. And I understand now there are two brand new medications and treatments which should be bringing everybody hope. So just talk to our audience about the new drugs and what's unique about them and why are they revolutionary and how are they different from what we've had in the past?
Mm-hmm. So maybe what I'll do is just spend 1 second talking about the medications that we've had for the last 20 odd years. This group of medications, they're anticholinesterase inhibitors, and there's also another drug
That's a big,
called,
long phrase right there,
Okay.
which most of us have no idea what that means.
All right. So those drugs are what we call symptomatic medications. So that means that they just treat the symptoms of Alzheimer's disease. they don't treat the underlying cause, the underlying pathology. An analogy would be, if you think about cancer, symptomatic treatments for cancer would be painkillers, whereas the treatments that actually treat the underlying cancer are called disease-modifying treatments. Now, the parallel with Alzheimer's disease is the symptomatic treatments are the ones which just help the dying brain cells, which is the problem in Alzheimer's. They help the dying brain cells to work a bit more efficiently. But at a certain point, they stop working because you've lost too many brain cells. However, the two new medications that have just come on the market, or in the last year in the US and more recently in the UK, those are what we call disease-modifying medications because they're designed to treat the underlying disease pathology. Now, those medications, therefore, are designed to keep those dying, stop those brain cells from dying in the first place. The two medications, one's called Kisunla or donanemab, and the other is called Leqembi or lecanemab. And we've been really fortunate at our 10 recognition health centres across UK and US because we've been working with these medications for the last number of years in clinical trial. So we've given over 9,000 doses of these types of medications. The class of medication that they both belong to is a monoclonal antibody against amyloid protein. So very simply, what happens is in this condition, for some reason, there is an abnormal buildup of toxic insoluble amyloid protein. This amyloid protein gets sort of like effectively dumped down on top of our cognitive brain cells, and it stops those brain cells from working normally. And like any cell in the body, like muscle cells or liver cells, if they can't work normally, the only way they respond is they just sort of like shrink and die. But most cells in the body can regenerate. The problem with brain cells is they can't regenerate. So once you've lost them, that's it. So the way these monoclonal antibodies, they're both, as I say, the same class, the way they work is they remove the abnormal accumulation of amyloid protein in the brain and thereby protect the brain cells from further destruction. Now, at this moment in time, these medications, again, they're most effective if given early. They will slow down further progression of disease and symptoms. So the big breakthrough is not only do they both remove the amyloid protein, the toxic amyloid protein from the brain, and bring it back down into the normal range, but that action correlates with slowing a progression of cognitive symptoms. And it's that correlation with clinical meaningfulness that is really the most important thing.
So these are really first-time breakthrough medications that we've never seen in our lifetimes.
Yeah, this is an historic moment in so much as it's the first time that there are medications, and it's like, it's always strange that there's none forever and then two come along at once, but that's just the way sort of like research and development seems to work. But yes, it is the first time that it's possible to actually slow down further progression of disease and symptoms.
So at Recognition Health, we've been doing clinical trials for all kinds of neurodegenerative diseases for quite a long time. Probably most people don't really understand how clinical trials work, particularly in this whole area of cognition and memory loss. And these two new medications, Leqembi and Kisunla, obviously came through years of clinical trials and have just been on the market within the last 6 months. Is that fair to say?
Slightly longer in the US and the last sort of like 2 to 3 months almost in the UK. Yeah. Well, and being approved gradually across the world.
And I understand Recognition Health was the first in England to be administering these drugs. Is that correct?
Yeah, we're actually the first in Europe to administer them.
So just say a word about clinical trials. How important are clinical trials in this whole world of research and seeking a solution to this terrible disease that we have?
So clinical trials are going on all the time across all aspects of medicine. And I think actually sort of like everybody was maybe more and for the first time really aware of clinical trials during COVID because there were clinical trials going on all the time to develop new COVID vaccines. So every drug that comes on the market has to go through clinical trials. And clinical trials is a highly regulated activity going on sort of like all across the world. And it's designed essentially once after sort of like animal trials and everything, there are 3 phases: phase 1, phase 2, and phase 3, sort of like clinical aspect of clinical trials. And phase 1 is really sort of like very much, it's all focused on safety, but very much focused on safety and dose, etc. Then phase 2 will be in a bigger group of people. And then finally, the phase 3 clinical trials are big clinical trials which will take place across all the world with people of different ethnic diversity, etc., in order to confirm that the medication is effective. And it's difficult. It's difficult to because the standards are set so high that a medication has to be both effective and obviously safe, and it has to be suitable for people of all different ethnicity. And so to qualify for a clinical trial or to get into a clinical trial, the only eligibility criteria is a clinical eligibility criteria. It's completely free to the individual in terms of any cost for coming into a clinical trial, and indeed, in most cases in the US, people are actually reimbursed for being in the clinical trial. And in almost all clinical trials, the pattern is that you go through a screening period where, in the context of Alzheimer's clinical trials, you'll get a very, very accurate biomarker-driven diagnosis. So you definitely have this elevated amyloid protein in the brain, which is the hallmark for the diagnosis, and or you may also have elevated tau protein in the brain, which is a very important component of Alzheimer's disease. And then you will be within a certain cognitive profile. So everybody coming into the clinical trial is sort of like has the same level of condition, and that criteria is also matched against the sweet spot for where that medication is expected to work. So it's very difficult to get into the wrong clinical trial. In fact, it's pretty much impossible. And then everyone who qualifies through all the screening assessments and tests, etc., will be randomly distributed by a central computer into taking either active medication or placebo. And the minimum would be 50-50 active medication versus placebo. In most studies, more people are on active medication than placebo. Then neither the individual nor the study team that are providing the medication and looking after the individuals in the trial will know whether those individuals are on the active medication or the placebo. They will then have whatever the period is, often about 18 months, where they regularly given the medication and they're followed very closely. And then in most clinical trials, at the end of that period, everybody will then be given the active medication. So it's like early access to the medication. Of course, these medications are not yet on the market. So up till very recently, the only way an individual could access a potentially disease-modifying medication for Alzheimer's disease was through clinical trials. So we've treated hundreds, if not thousands, of patients in clinical trials with a whole array of different medications, anti-neuroinflammatory, vaccines,
and a younger
et
and younger
cetera.
population. These trials are focused on younger and younger people because early diagnosis is so critical.
Yeah.
So as we're coming to the end of this, we know few things in life are free. I understand Medicare and TRICARE, and TRICARE is the health care for veterans and active duty military. They will pay, TRICARE and Medicare will pay for this. Most commercial payers are not yet paying for this. So we have people that are willing to pay self-pay. Is there any reason, if somebody can afford it, they would not want to rush to get on one of these new medications if they've got a diagnosis of Alzheimer's?
So in my view, no, I cannot think any reason. And if it was me, I would want to seek one of these medications. However, I think it is very important, and it's most important to be responsible with respect to this. Every drug and every condition will have a risk-benefit profile. And the most important thing with these medications is there are certain things that would put people at greater risk of developing side effects from this class of medication. So if you are taking anticoagulants, it's not advisable at all to take this type of medication. There is an apoprotein E genotype, and people who have an apoprotein G genotype, which is E44.
And none of us will know what that means, but I guess
No.
if you have it, you'll know it.
Yeah, you have
Someone
to test
would have
it.
told you.
Yeah, it has to be tested on a blood test. But really, there isn't time in this podcast, and I think this is something that I know a lot of people are very interested in. So I think we should
We will come back
do
and-
another podcast
Yes.
about. But I really want to say the most important thing is to be honest, the younger you are, if you do have a diagnosis, a biomarker diagnosis of Alzheimer's disease, then generally speaking, your condition is likely to progress more rapidly. So it's even more important to seek treatment, or equally important to seek treatment as soon as possible. But it is very important to discuss the risks and benefits with a very experienced clinician who really, who understands exactly the potential risks of these types of medications and what factors put certain individuals at greater risk than others.
This has been a fascinating 15 minutes. We could go on forever, but we're going to bring this to a close. There is so much more to talk about, and we're going to do that podcast after podcast. And I'm just so grateful for all the work that you're doing, our colleagues are doing, and how willing you are just to share this, because I don't know anybody who's not interested in this topic. So I'll say thank you, and we look forward to doing this again.
Thank you. I'll leave you with one message. Alzheimer's is a pandemic, and early action is the secret.
Thank you.
Thank you. Has this conversation left you wanting more information? Are you wondering what are the early signs of Alzheimer's? You and family members can take a quick test by going to thebrainandmindexperts.com.